I'm going to be talking about some work that we've been developing over the past couple of years at Edinburgh Uni with my colleagues Alexandra Blair and Professor John Frank, who unfortunately can't be here today. I came into post a couple of years ago in Edinburgh, having come from latterly working around childhood mental health difficulties. And there'd been a lot of discussion starting about ACEs in Scotland. And I was really struck by the Scottish Public Health Network report that came out saying that although we have various bits of information about household dysfunction in Scotland, we don't actually know much about the specific prevalence of ACEs in the general population in Scotland. And I particularly like this bit. However, if 9% of people in England have 4 or more ACEs, Scotland is likely to be worse. So I particularly like that section of the report. But we'd had a bit of discussion about, well, we know that Scotland do have poorer health outcomes than England. There's still some bits of that can't be explained. And could ACEs factor into that? So we started having conversations around this, and particularly around risk of ACEs and ACEs in different parts of the population. And this is where this study sort of came from. I'm going to talk to you about a couple of bits of work today. These papers are both under review at the moment, so unfortunately I can't share them with you. But please let me know if you want to be kept updated about them. The first study was broadly to explore the extent to which ACEs could be gathered using prospective cohort data. So we don't have any retrospective data on ACEs, but we do have this really rich cohort data in Scotland that we're really lucky to have. So we wanted to use this to see to what extent we could ascertain the prevalence of ACEs in the population of Scottish children, and particularly using this really rich data, we could look at things like who is more likely to be at risk of experiencing ACEs, which factors predict having any ACEs and more ACEs in the population. And we're particularly interested in the role of poverty in that. So I'll talk to you about this study first. We used the Growing Up in Scotland study. For those of you that don't know much about GUS, it's a national survey of children in Scotland. We're using the birth cohort 1, which was the first group of children to be followed, and they were born in 2004 to 2005, and there were just over 5,000 of them at the start of this study. And they were followed up annually for quite a long time, and now they're about every other year they're still following them up. And that's about 10% of the children that were born in that year in Scotland, so it's a reasonable number. The data were taken from, the sample was taken from child benefit records, and that's important to note, because before the survey team received the sample, child benefit remove anything that they deem to be sensitive cases. Now, some of those children will have already experienced ACEs, so things like if you'd had a death in the family recently, so this is before about 8 months of age, but there will be some children who had a parent die in that time, parent go to prison, that sort of thing. Those children were removed from the sample. So what we see within this, actually there's likely to be more ACEs in the general population, which is worth bearing in mind. We had data up to the age of 8 when we looked at this, so we don't have as many as the retrospective surveys that look back over the past 18 years from an adult's point of view. We're looking at ACEs up to the age of 8, and the children, we had about 3,500 children still in the sample at that age. And we calculated ACE scores using data from every sweep. So wherever we could find data about ACEs, we counted it. So for some of those ACEs, they will have been asked about every year, annually. For some, they might only have been asked once or twice. And this is what we found. The ACEs that are in green or blue on this slide are the ACEs that we managed to get data on. So we managed to get data on 7 ACEs in childhood. The 2 that we didn't manage to get anything on were emotional abuse and neglect. And sexual abuse came up in an open question about adverse experiences. However, there were very few cases within that. So we haven't included that in this analysis. And this is what we found. These are the levels of ACEs by cohort. You have the GUS figures are in red here, and for comparison, you have the Welsh figures and the original Felitti figures as well. And we found the most common ACEs that people had experienced were parents having a mental health problem, and parents having ever divorced or separated at any point. And that includes child death as well in that one as well. Parents in prison, we weren't picking up many at all. It was something like 0.4%. We expect we're missing people there, because that was far lower than we expected to find by the age of 8. Otherwise, things are pretty comparable, though drug and alcohol misuse was lower than the original study, but fairly similar to Wales. Some of these, the things like drug and alcohol misuse, mental health problems, these were reported by the parent themselves. In some cases, mental health difficulties used a scale, the depression, anxiety and stress scale. We had to decide on cut-offs for some of these. So for some of them, it depends a bit on how we analyse the data as to how many people are included. But these are the levels of ACEs compared to the original study overall. So we found far fewer children overall had no ACEs, and this was by the age of 8. So just 35% had no ACEs, compared to about half of children, or half of adults who experienced ACEs in the Felitti study. We had far more children who'd experienced 1 or 2 ACEs, but fewer having experienced 4 or more at the more extreme end. But you have to remember they've had less time to accumulate more ACEs. There's also a couple of ACEs that we're not including in this. So overall, we had about 10% of children had experienced 3 or more ACEs, which is what we went on to look at in the analyses. So we looked at who was more likely to have 3 or more ACEs at age 8. And the children's odds of having 3 or more ACEs were associated with being male. Now that's an interesting one, because a lot of the studies that look at the adult retrospective data actually show that girls have higher levels of ACEs. And we wondered if that some of that was around girls accumulating ACEs later, possibly, particularly around things like sexual abuse. It might be the ACEs that we are picking up in the study. Possibly boys pick up ACEs earlier on. Living in a household in the lowest income band was by far predicted the highest odds of having 3 or more ACEs. So if you lived in a household in the lowest income band compared to the most affluent households, you had odds 6.5 times higher of having 3 or more ACEs, and I'll go on to talk a bit more about that. Having a mother who was aged under 20 at the birth of the first child increased your odds, and also living in an urban area as well. We were really struck by the disparity by income. There's a lot of talk in the ACE literature about not really acknowledging income as part of ACEs. Poverty isn't an ACE. And a lot of the adult data has not necessarily dismissed poverty, but certainly it purely looks at your number of ACEs. But what we're seeing is that ACEs are really clustered in areas of multiple deprivation. And I think this was particularly striking for us. So at the age of 8, about 1 in 12 children at the bottom, in this 8% in the bottom income quintile, had no ACEs, and that was compared to 1 in 2 in the most affluent areas. So over half of children in the most affluent areas had no ACEs by the age of 8, and we found this really striking. And it's the total opposite. If you look at the dark figure, the dark bands at the top, about 1 in 10 children in the lowest income households had 4 or more ACEs, and this was by the age of 8, compared to 1 in 100 in the most affluent quintiles. And you can see that dose response throughout there. So we thought that was really striking. We looked, this is a slightly technical bit that I'll gloss over somewhat, but if you want to talk to me about it later, I'm quite happy to discuss it. We wanted to know basically if we got rid of that, if we got rid of income inequality, we raised everyone above the basic income line, to what extent would we get rid of these ACEs? And this is quite a crude measurement, but the results suggest that in about 22% of cases where the children experience 3 or more ACEs, this can be directly attributed to poverty. So there's been a lot of discussion about basic income in Scotland at the moment, and it could be that raising families above that basic income level might relieve some of the pressure and reduce ACEs in the population. This led to our second piece of work, which was conducted by a Canadian PhD student who came and did a placement with us in Edinburgh. We asked her to look at whether there are resources for the low-income households that could mitigate the effects of poverty on ACE incidence. So looking at whether there are support mechanisms or community resources that might lower those ACE scores. And it uses the same sample as the first study. And the things, she did a review of the literature and looked at what data we had available. And the things that she looked at were stable housing, which has obviously come up a lot recently, transportation services, so that was either having access to a car or having good bus services that were locally available, breastfeeding counselling. It was tricky to get anything that was sort of additional postnatal support, and that's really what we were looking for there. Childcare services and a local park or play park for children living in urban areas. We'll go on to talk about that later. So she was looking at children from low-income households and their ACE accumulation leading to poorer overall outcomes. She wanted to know whether these resources would moderate those effects. This is a slightly complicated table, but essentially what it highlights is the proportion of the relative income inequality, so there's differences between income groups in the prevalence of ACEs that could be eliminated by providing different resources. And the one thing that came out as being significant in this was transportation. So having access to a car or to good bus services, public transport services, seemed to eliminate, it suggests that it would eliminate about 21% of that inequality in ACEs. And this led us to various discussions about, well, what could that mean in reality? Could you pilot putting in really good public transport in deprived areas? And what would that mean for people? How do we interpret these results? Transportation can lead to lots of things. It can mean that you can access resources out with your immediate community, which is much easier if you can easily get around, access different resources. There's a sense of control over your life, that if you can decide where you're going to go rather than being reliant on what's brought to you, and that independence that it gives you as well. It might lower stress if you're accessing more support. Then these have all been shown to add to better outcomes generally. So that's a bit of food for thought. We've now linked these data, the GUS data, with routine health data. So we can look at hospital data for accidents and injuries, for various other things. Unfortunately, I don't have those to show to you today. But what I have been able to look at is the links with the outcomes that we have within GUS. So these are all at age 8. And they show similar patterns to what we've seen in other studies. Overweight or obese is quite an interesting one, because we see that the more ACEs that you have up to 3 increases your likelihood of being overweight or obese. But actually, if you have 4 or more, you're less likely to be overweight or obese. And that's quite interesting in itself. The others all show similar patterns to what we'd anticipate. So the more ACEs you have, the more likely you are to have additional support needs, to rate your health as fair or bad, to have a disability or a long-standing illness. And if you have 2 or more ACEs, you're more likely to have had an unintentional injury in the past year at age 8. GUS also collects Strengths and Difficulties questionnaire, which allows us to look at social, emotional and behavioural development by ACE scores. And again, we see these patterns. It's particularly striking for conduct problems, I think. The only one that wasn't statistically significant here was the pro-social skills, which is the positive rated part of this scale. And the other outcomes that we just had a quick look at, if a child has been supervised following a court case or a children's hearing, it's more likely if you have 4 or more ACEs, although we were surprised that actually it's that low. And parental aspirations were lower if you had 4 or more ACEs. So we looked at whether the parent expected the child to stay on at school after the age of 16. But I think it's worth saying the thing that rings through my head when I look at this is my statistics lecturer from my postgrad course, who would always say that correlation is not causation. And I think that's really important to remember. And some of the studies that some of the analyses that we are planning to do in the future is to look at, is it the ACEs that are causing these? Or is it other things that are going on in the children's lives or the parents' lives that are associated with these outcomes? A bit controversial, I know, among the ACE community. There are various strengths and weaknesses of this study, and I think this is worth pointing out because I think it's interesting in relation to all the data that we're looking at here. The real benefit of having these cohort data is that we have this really rich wealth of data to be able to look at parenting and all different things as well. And response rates are high, but we're possibly missing some of those children with the most severe ACEs. There's a really interesting discussion to be had around the role of retrospective data. We know from some evidence that people rate their ACEs differently depending on their mental health. And when we're looking at a lot of ACEs in relation to mental health outcomes, that's really worth bearing in mind because actually we don't know which comes first particularly. We don't know about the experience, if it's the experience of ACEs or if it's the memory or impact that they've had, particularly very early ACEs. There are some things that arguably adults won't know about. So there's long been cases of parents going to prison and children not being aware of that when they're very young. Things like parental mental health difficulties and substance abuse problems. Some parents can hide those and do it quite well. So we collect far more data on actual experience of ACEs rather than adults' memories of ACEs. And particularly some of the studies that have been done, people are looking back sort of 60 years. That's quite a long time for recall. However, there are downsides to this as well. There's social desirability arguably on both sides, that people might not want to report, but particularly for parents reporting about children's adverse experiences, there might be a fear of reporting some issues. And also parents might not be aware. If it's parents reporting, we have both parent and child data in this study, but if it's parents reporting about their child's ACEs, there might be some things that they're not aware of that are happening outside the home. I'm going to skip past that because I'm running out of time. So our future work, we're wanting to explore the linked data in relation to ACE scores, and we'll be able to look at that at a slightly later date. We're also, because GUS is continuing to collect data, the next sweep of data has in it information about whether there is a stable supportive adult in the child's life, so we'll be able to look at that and attachment. And we've just finished writing a funding bid to collect data on the parents' ACEs within the GUS cohort so that we can look at those generational cycles. And alongside that, we're also wanting to look at parental neurodevelopmental disorders like ADHD and parenting to look at what are the links in that cycle, and what supports could we potentially put in place to break cycles of ACEs. And we continue to look at prospective ACEs up to 18, and as further linked data become available, for example education data, we'll be able to look at the relationships there as well. We're always open to any other suggestions and collaborations equally if anyone's interested in looking at particular bits. There is a huge amount in the GUS study that we could potentially look at. So overall, 2/3 of Scottish children have one or more ACE by the age of 8, and this arguably compares unfavourably with previous studies, but actually measurement differences make it a bit tricky to compare directly. But what is clear is that many children are experiencing far from ideal childhoods, and that arguably some of this could be reduced, could be improved. There's few experiencing 4 or more ACEs, which is the strongest predictor in the literature of later adverse outcomes. And it's really important to note that ACEs are clustered among children who experience the most deprivation generally. And I think the question around could improved public transport help support lower income families to avoid ACEs, and it is an interesting one in itself and worth looking into more. There's lots of people to thank, including all the children and families who participated in GUS. Thank you.